We now have our public testimony, and we're very eager to hear from those who've come to visit with us today. And Marilyn, we'll start with you if that's okay.
Okay, thank you. I'm Marilyn Golden. Is this right on the volume now? I'm Senior Policy Analyst at the Disability Rights Education and Defense Fund. We're a leading national law and policy center on disability civil rights, and we have many concerns to convey today, the common thread being the many stories we hear from people with disabilities again and again, illustrating that our lives are seen as less worth living than others, so much less that healthcare providers often think death is the correct course. They press this viewpoint on us, our families, and sometimes overrule us when we disagree. Lest I seem overly dramatic, let me give you an example, a story. A true story about a young disabled woman who worked for the Center for Disability Rights in upstate New York. At the age of 19, she'd had a car accident, and while lying in a hospital bed with a ventilator, the doctors would ask her mother if she was ready to pull the plug. Why would I want to do that, she would ask. The doctors answered, what kind of life will she have? She won't be able to dance or walk or work or have a social life or be independent. By the way, I do every one of those things, and I bet Terry at this point does too. Over and over, Terry had, this happened. Terry had a rough time medically, but eventually she was spending hours a day off the ventilator, and the doctors were still asking. If she said no, she didn't want to, they would give her morphine and keep her off the vent. When she returned a year later, after a lot of hard work, with a power wheelchair and no ventilator, looking like she was living a real life, the doctor's jaws dropped to the floor and their eyes began to fill with tears. They'd always meant well, and they thought they'd been doing the right thing. Today, Terry's still working for disability rights, and she has a darling young daughter, and I'm so glad she went against the advice of her doctors. A related problem we see in the end-of-life field is a deep misunderstanding that the only problem to be addressed is overtreatment at the end of life. A balanced approach would also address something less, very much less well acknowledged, that there is another problem, undertreatment at the end of life, sometimes happening in the very next hospital room, and pressure against expensive life-saving treatment due to healthcare disparities, discrimination, including but not limited to disability discrimination and other problems. And these various issues come up in a number of ways. Futile care policies, which allow healthcare providers to use their quality of life judgments about disabled people to overrule our decisions to receive treatment, discrimination in organ procurement and organ transplant practices, and rushing to judgment when a newly injured person is diagnosed in a persistent vegetative state. As a final point, we and many other disability organizations oppose the legalization of assisted suicide, which is too dangerous, a prescription for elder abuse, and when it's legal, it's the cheapest treatment available, which is a terrifying thing in our profit-driven healthcare system. Thank you so much.
Thank you very much.
All right. My name is Renee Berry, and I'd like to start today by thanking the members of the Institute of Medicine's Committee on End-of-Life Care. Your groundbreaking work has laid the foundation for my passion. I feel grateful to have gotten to know many of you over the years and sincerely appreciate following your work. Today, I'm not speaking on behalf of a provider or an association. I come to this microphone to continue what many of you know I do online every day, to amplify a voice for the public. I represent just one example of the possibility to empower everyday advocates and engage people from all backgrounds to be palliative care ambassadors for quality of life. I am hopeful that the work of this committee will contribute to helping everyday people understand palliative care, and that palliative care can be at the table, collaborating with their healthcare team from the point of diagnosis of a serious illness. There is a strong and urgent need for clear messaging about palliative care. There are currently a lot of inconsistencies with how palliative medicine is discussed among clinicians. There's a lot of confusion about the right time for palliative medicine, as well as the basic differences between early palliative care and hospice. These inconsistencies and the common confusion among professionals are barriers to people accessing the care that they need. The public deserves the opportunity to understand that hospice is specialized care for the end of life, and that palliative care specializes in intensive symptom management at the same time as their curative treatments for any serious illness from the time of diagnosis. Using language that refers to a, quote, good death does not effectively depict the breadth of what this field provides to patients and their families experiencing serious illness. This term undermines language focusing on quality of life, language which is supported by CAPC's research as the type of thing that people actually want to talk about. Wherever people are with serious illness, discussions about quality of life deserve attention. Please also consider messaging guidelines about references to, quote unquote, stopping treatment. This term lays a foundation for unnecessary fear for patients and families and furthers the notion that the healthcare team is abandoning them at a time where they need the highest level of support. Patients do not need to stop treatment. Palliative medicine is treatment. Hospice care is treatment. There is a variety of different treatment options, and patients deserve to consider with clear information for informed medical decision-making on their goals, based on their goals. There's a large opportunity for this committee to instigate fantastic public engagement. I will make a language clarification note here that while public engagement is sometimes confused with marketing, these terms are not synonymous. Public engagement is content that is designed to inspire sharing and conversation. I serve as the Digital Director for National Healthcare Decisions Day, an initiative dedicated to educating and empowering the public and providers about the importance of advanced care planning. We have over 1,000 organizations participating each year. And one recent successful example of a public engagement campaign is a quote that we shared from Dr. Ira Byock just this April that was viewed over 59,000 times and shared over 588 times just on Facebook. With my NHDD hat on, I'll also ask for the committee's thoughts on creating an infrastructure that recognizes advanced care planning as a normal part of good healthcare for all adults. While many of us understand that advanced care planning is not by any means exclusively a geriatric issue, I'm not aware of many primary care physicians that check in about updates annually to an advanced directive starting at the age of 18. As a co-founder of the Hospice and Palliative Medicine Tweet Chat, I have been honored to be a part of many public interdisciplinary conversations online. Through this group, which we founded in 2010 of July, we're approaching our 3rd anniversary, we have generated over 100 million impressions to raise awareness for palliative care and also hospice. Please consider ways to design opportunities for the committee's work to be interactive and easily amplified. This does not need to be expensive, but it does require strategic attention. Dean Pizzo is approaching the microphone, and I did not get to finish, but I hope that all of you will be able to look at the rest of my comments later. And I will close with one quote. Just a couple of weeks ago, a well-known venture capitalist in Silicon Valley, Vinod Khosla, gave a presentation at the Graduate School of Business, and he had a slide that read, "Entrepreneurs will ask the naive questions that uncover hidden assumptions." So my final ask to the committee today is to design an environment for naive questions. Design opportunities for fresh-eyed entrepreneurs to bring their energy to increasing access to early palliative care.
Okay, thank you very much. All right, thank you.
Good afternoon. My name is Amy Vandenbrook, and I'm the Executive Director of the National Pulse Paradigm Program, as of January, anyway, of this year, and it's been a privilege to be part of that program. I wanted to thank Susan for describing PULSE, so at least I'm starting off on a foundation, and I'm just going to build on it a little bit by describing a little bit more of the national organization and expanding on the resources available. The National PULSE Paradigm Task Force is comprised of members from states who have achieved the mature status, which is 2, Oregon and West Virginia, and 14 states that have reached the endorsed status. And this group is the one that provides guidance for other Pulse Paradigm programs, and it focuses on the tenets of the program. As Susan mentioned, Pulse is not an event, but a conversation. So one of our goals is to promote the conversation between the patient and their healthcare provider, talking about the condition, the current condition, prognosis, the risks and benefits of treatment, and the patient's values and wishes, and taking that conversation and putting it on a tangible form, the Pulse form, which is a way to capture the information for use in a crisis situation and ensure that a patient's wishes are honored. It's shared decision-making captured in a form that can be easily used. The task force also provides guidance, requirements, and suggestions for forms. A big part of the Pulse paradigm is to promote sharing. So we share lessons learned by states like Oregon, West Virginia, Massachusetts, and California, so that newer states can build on a better foundation. We share guidance about what helps make a program sustainable, what people you want at the table when you start, how to think about funding short-term and long-term, as well as legislative considerations. We help avoid confusion for new programs, and we help them start a better pilot program with improved education, training, and other things that they need to think about so that they can be more successful overall. Mentorship is another big thing. Susan mentioned a formal mentorship program, but we also have endorsed states that are really excited to help informally mentor a lot of the states that are developing. For resources, the National Office is trying to be a repository for all information Pulse so that we can share and make every program a better program. So we have resources for patients and families where they can learn more about Pulse and find out how to get information about their state. We have information for healthcare providers, or professionals, excuse me. And then we also have information for developing states, all the way how to become a program from the starting point to becoming a mature program. And then information for researchers, because we can continue building a better program by looking where we've been and the information that we have. The website, the national website, was launched in February of this year, and we're constantly developing it and building our resource library up so it's very easy to find a lot of information. And of course, if you can't find something, feel free to contact me. Pat certainly has my information, but she also is a great resource herself. And if you need anything else, please let me know. I know it's blinking, but 5 seconds. I just want to point out on the map that Susan had on her last thing, we did note that there are a couple of states that are Pulse-like, and I just want to point out that those are states that we still want to keep in the fold, but don't completely subscribe to the tenets that the task force has developed. Thank you.
Good afternoon, I'm Pat Dotson. I'm here representing Compassion and Choices, the largest national nonprofit organization dealing with care and improving options at the end of life. I want to thank the committee for taking on this enormous task of looking at healthcare, the whole healthcare continuum. The part that I would like to focus on is the point at which a physician knows that a patient's prognosis is imminent death. Although many physicians tell their patients the truth, there are many who recommend treatments that will not alter a patient's progress, but will degrade the amount of time they have left. A study published in JAMA shows that treatment in intensive care units in the last month of life is increasing. The accompanying editorial in JAMA said, the focus appears to be on providing curative care in the hospital, regardless of the likelihood of benefit or the preference of the patient. Therefore, my first recommendation is that physicians have to inform patients of their prognosis and whether there is any treatment that is likely to affect their life to add any quality time. The California legislature in 2008 began writing a bill called the Patient's Right to Know. And the California Medical Association said they would only support that if the words, if asked, in other words, and only if the patient asked the physician for information about end of life, would that conversation take place. New York, fortunately, passed a much better law. Their law requires the physician to tell the patient. I think it's the New York model that should be focused and used as a model for the rest of the country. In the original healthcare legislation President Obama sent to Congress, there's language providing reimbursement for physicians for having the end-of-life conversations with their patients. But when a politician dubbed these vital conversations, quote, government-sponsored death panels, there were few who defended the truth. Patient advocacy groups throughout the nation were shocked this part of the bill was not defended and supported. End-of-life care must include the option of taking a medication that guarantees a comfortable, painless death for people who are mentally competent and for whom death is imminent. The history of the Oregon law shows that it is used infrequently, which we've heard today, and that it has never been abused. It is patient-centered care at its finest. Only the patient can request the medication. They have to request it numerous times, orally and in writing. It must be self-administered. Studies show that the desire for this option is growing as the baby boomers have finally realized they are past middle age. We are beginning what will be the largest civil rights movement of this era, allowing people aid in dying if they are competent and terminally ill. I have a lot more to say, but I see the red light. Thank you.
Thank you very much. And I know that each of you have lots more to say, and we really appreciate hearing from you. I think it's very, very important. I'll ask you, however, now to go back to the audience, and we're going to ask the next group to come forward, and that's going to include Paula Taubman, Thomas White, Stephanie Harmon, Devin Davies, and Heidi Engel. And while you're all coming up to take your seats, Paul, if we can begin with you and go to the podium, please. Thank you very much.
Good afternoon. I'm Paula Taubman. I'm the Northern California Director for Compassion and Choices. Thank you so much for this opportunity to speak with you. Compassion and Choices is a national nonprofit consumer organization dedicated to improving care and expanding choice at the end of life. We seek to make available the full range of end-of-life care options and choice, guided by the principles of patient-centered care. Today, I want to focus attention on the momentum for death with dignity that is building throughout the nation. The public is demanding, and legislators and physicians are increasingly responding to the cries for the full range of end-of-life choices, including aid in dying. 3 factors are converging to drive this change. Overwhelming public support for end-of-life choice, the aging of the baby boomers who want to control their end-of-life choice, and a robust grassroots movement that can convert this desire into law and practice. Political and legislative action is beginning to catch up with public opinion, which consistently is in the 60 to 70% support range. The pace of establishing aid in dying is accelerating. Oregon and Washington enacted aid in dying laws through citizen-passed ballot initiatives in 1994 and 2008, respectively. In 2009, the Montana Supreme Court ruled in a case brought by Compassion and Choices, Baxter versus Montana, that the state's public policy supports mentally competent, terminally ill patients being able to choose aid in dying. In Hawaii, under the current constellation of laws in the state, aid in dying is legal. And there is significant legislative activity throughout the country in the 2013 legislative sessions. At least 7 states consider death with dignity bills, including Connecticut, Kansas, Massachusetts, as we've heard, Montana, New Hampshire, and New Jersey. And of course, the governor of Vermont, just this month, signed into law the nation's first death with dignity bill passed by a legislature. The structure of the bill is significant. It transitions from a process mandated by government to professional practice standards established by physicians. It is likely that lawmakers in other states will follow suit on the winds of the Vermont law. Ultimately, this personal choice should be left to patients, their families, and their doctors. And it should be guided by medical standards, not the whims of politicians. Thank you.
Okay, Dr. White.
Thank you. I'm Thomas White. I'm a member of the Board of Directors of Compassionate Choices, and I'm also speaking from the perspective of someone who's been diagnosed and treated for stage 4 metastatic throat cancer 5 years ago, and whose wife was diagnosed with advanced untreatable cancer of the pancreas 3 years ago and only lived 4 months. Americans are free to choose how they live, and when the time comes, we should have more say in how we choose to die. This private, personal decision, which is literally our last human right, belongs to all Americans, free from government and religious interference. Ultimately, this personal choice should be left to the patient, the family, and their doctor, and it should be guided by a medical standard of care without interference from Congress or religious institutions or politicians. In Oregon's 15 years experience, the law has worked as intended with none of the problems that opponents predicted. The law benefits end-of-life care in general, as we could see from a recent article in the New England Journal of Medicine about Washington's experience, and there has not even been one incident of abuse. Some disability rights advocates have expressed concerns that disabled people would be forced to end their lives prematurely. However, a University of Utah report found no evidence of heightened risk for the physically disabled or other vulnerable populations. While these concerns are real, they should not be used to restrict the rights of others at the end of their lives. Support for end-of-life choice is consistently strong, as has been mentioned earlier. However, a vocal minority, knowing their views are not broadly supported, uses scare tactics and misinformation to frighten voters and intimidate legislators to block aid in dying policies of all types. Opponents of aid in dying wrongly call this legal choice suicide or assisted suicide. These words are inappropriate and inaccurate. Many end-of-life practices predictably hasten the moment of death. These include refusal or withdrawal of life-sustaining treatment, such as ventilators or dialysis, palliative sedation, and voluntarily stopping eating and drinking. Dying individuals who make the private, personal decision to bring about a more peaceful death do so after intense, rational consideration based on the data. No one should have to suffer at the end of their life. Many dying patients suffer or spend their last days receiving unwanted medical procedures in an intensive care unit, as I have direct experience with. Others fear their pain will become unbearable. Every person should have a full range of end-of-life choices, including the right to request and obtain life-ending medication. Thank you.
Dr. Harmon.
Good afternoon, everyone. Distinguished members of the committee, welcome to Stanford. Dr. Pizzo and Mr. Walker, thank you for your leadership. I'm Stephanie Harmon, and I'm the director of our palliative program here at Stanford Hospital. I am privileged to have the opportunity now to share comments on behalf of our program. While there are many aspects of end-of-life care to address, we would like to bring to your attention the following challenges: access to hospice care, ensuring that patients with life-limiting illnesses have the opportunity to hear about all the options, and training our future clinicians to communicate about end-of-life care. These are areas where we have been, frankly, stymied. Regarding hospice access, I can vividly recall conversations with patient family members who wanted their loved ones closer to their home in a nursing facility, but they could not afford the room and board fees. And consequently, many patients like these pass away in acute care hospitals rather than in a setting closer to home. The patients receive higher intensity, unwanted care at the end of life rather than being with their loved ones, and the system bears a much higher cost. Both perverse outcomes are due to inappropriate structuring of benefits, and clinicians then spend precious time trying to figure out workarounds for these patients and their families. And these challenges deserve more than workarounds. They should inspire intense scrutiny and reform of the Medicare hospice benefit, which the Institute of Medicine could recommend. Regarding the issue of informed refusal alongside informed consent, too often the options for end-of-life care and symptom control are discussed too late or never. Patients and families should not have to worry that they are not fully informed, and it should be imperative that clinicians inform fully or request assistance if needed to discuss available options. And large polls done by the California Healthcare Foundation and others show patients feel unequivocally about their need to know. This needs to be a standard of care, like prompt antibiotics for sepsis or aspirin for heart attacks, not optional, but a core measure of quality enforced by CMS and the payers. And regarding education, this committee in 1997 very rightly identified that, quote, dying is too important a part of life to be left to one or two required but poorly attended lectures, to be considered only in ethical and not clinical terms, or to be set aside on the grounds that medical educators are already swamped with competing demands for time and resources. I heartily agree. The other hat I wear is that of an associate program director for our medicine residency, and that statement from the committee still resonates to this day. I urge the committee to revitalize the professional preparation recommendations made in 1997, particularly those centered on developing communication skills for difficult conversations. Too often, the first time a trainee has to state that a patient is dying is to a real patient in a real family, rather than in a simulation or a teaching session. Let's change this rubric and require deliberate practice and training in these skills as part of all medical school and graduate medical education curricula, another area where the Institute of Medicine could play a leading role. And in sum, we would ask that you concentrate on some of these issues in your deliberations and make specific recommendations to accrediting and regulatory agencies to ensure our patients get what they need and deserve. This would be a great gift indeed. Thank you.
I'll just say ditto. I'm watching the clock. My name is Devin Davies. I'm the Executive Director of Children's Hospice and Palliative Care Coalition. I want to first just thank the Institute of Medicine. I wouldn't be here if it wasn't for a report that came out in 2002, When Children Die. And I see a lot of heads nodding. It was a report that brought about nationwide effort to change and improve the way that we provide care to children at the end of life. And through CHPCC, through the advocacy work and education and program development that we've done here in California, we've opened up a lot of opportunities for children and their families to access this care. I think we kind of had this mentality that it's like Field of Dreams, that if we build it, they will come. And now we've built these policies into place, we've developed these programs, and we found that we're still challenged because a lot of agencies would love to be able to provide this care to children and their families, and they just can't afford to do so. So I would say that one of the things that we definitely need to address as we go forward is looking at the reimbursement rates. As Myra Christopher so eloquently said, let's look and focus on not on the outcomes, not on the prognosis, and on the needs of the children and their families. The other piece I would say is that we don't always know who is going to be having these conversations with the children and their families. And sometimes they don't even know when they're having those conversations. We have a blog, and one of our bloggers, Chelsea Lane, who recently passed away, was 16 years old, and she was laying in her bed, and she was intubated, and she was unable to communicate. And the physicians were talking over her about what her prognosis looked like and how she had congestive heart failure, and they weren't sure what was going to happen. And she's laying there thinking, I'm dying, and nobody's talking to me. She later went on and wrote a letter, a very passionate and compassionate letter, that I would encourage you to go online and read, where she talked to her physicians and said, I know you're all trying to do the right thing, but you need to remember that I'm here, that when you're having these conversations, you're talking about me. So I would say in California a while back, and I don't know all of the ins and outs of this, you probably will, but physicians were required to get 12 hours of training in pain and symptom management. Well, why not get 12 hours of training in palliative care? How to have these conversations. Because we don't know who's going to be sitting there at the table. We don't know when that moment is going to come. So I think the only way we can go about in getting more comfortable is ensuring that everyone has some experience, has the opportunity to get some training in having these conversations. Thank you very much.
Thanks to the Institute of Medicine for allowing me to speak here today. My name is Heidi Engel. I am a physical therapist, but today I speak to you as a representative of many things. I represent an end-of-life caregiver who took care of my sister when she died in 2006. I represent a spokesperson for the American Physical Therapy Association. I'm also a consultant for the Society of Critical Care Medicine and the Institute for Healthcare Improvement. I'm a physical therapist with 26 years of experience, presently working in the intensive care unit full-time at UCSF Medical Center. So I spend a lot of time with terminally ill people, and I've attended to the death of numerous patients. And I want to be here to represent the quality of life and the dignity that I know many who have died in the hospital would like to have had at the end of their life, and that in the home, as a physical therapist in the home hospice setting, I was often privileged to provide. People who hire me for home hospice hire me privately because Medicare technically pays for physical therapy for home hospice, but in reality, it tends to cover about one visit because of the way the funding is covered. So people would hire me privately, and you may wonder, why would you hire a physical therapist if you're terminally ill? Most people wonder, what is the role of a physical therapist in that setting? So there are three things I want to remind you that we provide, all related to quality of life at the end of life and dignity, but also a lot of communication. The physical therapist will often know the patient and the family member in a way that the other healthcare providers don't. I often have a tremendous amount of insight into what is going on with the patient, and often am one of the first people to understand that the person's life really is ending. So here are the three things we offer. Mobility is life, mobility is medicine, and your patients, even your most sedentary patients, will recognize this. When a patient is able to continue moving, when a patient is able to toilet not in bed, you wouldn't believe how much this can mean to them and to their family members. When a patient is able to move and be alert and awake to have meaningful end-of-life conversations, this is a huge gift we can provide to them. Mobility is a tremendous yet neglected vital sign and assessment tool. So through my practice of consistently monitoring and assessing a patient's mobility, their physiologic reserve, I understand if they're terminally ill, if they're really at the end of their life, or if they have a collection of diseases that perhaps we could still medically manage. And finally, I want to say that what we offer is a great bridge between physicians and the family and the patients about what they need and most value at the end of their life. So I ask you to consider the role of the physical therapist and the consulting with the American Physical Therapy Association as part of your recommendations. Thank you.
Thank you. Thank you very much, and thank you to this group of panelists. I'd like to now call our last group, Alberto Molina, Angelica Villagran, Johanna Parker, and Carl Steinberg. Okay, we'll begin with Alberto Molina.
Yes, good afternoon. Thank you very much, School of Medicine and also the Institute of Medicine for this opportunity. My name is Luis Alberto Molina. I'm the Assistant Director for Interpreter Services here at Stanford Hospital. I'd like to share a short story before I start, and that is a true story. There were two physicians from the Bay Area who are married. They took a trip to Paris, and during the flight in the middle of the Atlantic, the husband had a stroke. the wife, with her physical training, with her training as a physician, did the best that she could to support her husband and to assist him until they were able to arrive and land in Paris. An ambulance was waiting, and then they went to the hospital. When she came back to the United States, she expressed how frustrated and anxious she felt for hours because she couldn't find anyone who could speak English to her and explain what she needed to know. So many panelists expressed before the importance of communication. So interpreters and translators, in healthcare assist physicians and other providers because clear and complete communication make it possible for providers to explain options, set clear expectations, avoiding misunderstanding and of complications that affect healthcare costs, treatment quality, and provider-patient relationships. So what I like to recommend to the panel is the importance of using professional interpreters. What I mean by that is 3 recommendations. One is that the physicians, the new clinicians, the residents, they need to be trained, at least some basic training on how to work with interpreters, and that would allow them to work more effectively when they communicate, and also to use the resources responsibly, more effectively, being in a fiscally sustainable manner. The other part is, in regards to the professionalism, is that the hospitals and the physicians should expect and support those who are already trained with bilingual medical terminology, and also those who adhere to national standards of ethics and professional standards that are aimed to support the relationship between the provider and the patients and their families. Thank you. Thank you.
Ms. Villagran?
Good afternoon. Buenas tardes. My name is Angélica Villagran, and I am the VMI coordinator here at Stanford Hospital. VMI stands for Video Medical Interpretation. I want to thank VJ for inviting me to be here today. And I want to thank all of you for your attention. I want to just express that I really appreciate when a provider who is bilingual uses their skills to bond with the patients, because that is great, to bond with them and establish a relationship. But I also really appreciate it when they know their limitations as far as language is concerned. We want to make sure we come across and as eloquent as we can. So what I recommend, if you speak a second language, to bond with the patient in your second language, but then use an interpreter to be able to express yourself fully and to fully understand what the patient is telling you. I have witnessed conversations where a physician is bilingual but not fully bilingual, and then the patient can tell that, so they adjust what they're telling them in order to, be understood, but they're not fully understood and they're not fully expressing themselves. So I would really, truly encourage the use of medically trained interpreters. In your consideration, I would also bring to the table the fact that not every hospital has fully trained interpreters, so testing would be wonderful, both for bilingual staff as well as for interpreters. And the use of ad hoc interpreters could be a true problem. There could be many issues that could happen from that. So I just want to also stress that, that the patients are in a highly vulnerable stage. Like we heard everybody say that they're very vulnerable. They're at the worst or most stressful stage of their lives. The fact that they don't have the language is an added stress. So please keep that in mind, and please always use an interpreter when needed. Thank you.
Good afternoon. I'm Johanna Parker. I'm the lead interpreter for education and training here at Stanford. And I also teach a training created by the California Healthcare Foundation for interpreters on interpreting in palliative care. So throughout the day, we've been talking about communication, communication, communication. And obviously, when you have limited English proficient patients, that's what your interpreter will provide. But what should be a clear next step, and isn't always, is that interpreters should then be considered part of the healthcare team and not a tool for communication. All of the recommendations that we're making today from interpreter services are recommendations for the entire system, but because communication is so crucial in palliative care, our recommendations, we're even stronger here. So it's really important to use professionally trained interpreters and not ad hoc interpreters, people who are bilingual and may have done it before. If the interpreter is part of the healthcare team, just think about it. Would you use an ad hoc social worker? Oh, the patient's upset and the social worker's not available, so let's just grab another nurse or a medical assistant who knows how to talk to people and is nice. Of course you wouldn't. The same thing goes with language access, and communication is so key. You don't want to put the communication in the session in the hands of somebody who isn't professionally trained to do it. The goal of a professional interpreter is to support the provider-patient relationship. And trained interpreters are experts in medical terminology, have strong memory skills, and are familiar with the culture of biomedicine, both in this country and usually in the country of origin of the patient. So they're also better prepared to accurately render the subtleties of language used in end-of-life conversations. Increasing training opportunities for interpreters on interpreting in palliative care and dealing with compassion fatigue are popping up all the time. So it sounds great, use trained interpreters, fantastic. Even here in California and at this institution, with highly developed interpreter services department, it can be a challenge. So what about places where there are fewer resources, in the middle of rural America? There are new technologies that are making it possible to provide professional interpreter services all over the country. This includes phone interpretation and video interpretation. If providers have to use external agencies, then lobbying needs to be done to make sure that those agencies are properly training their interpreters in palliative care. There are only a handful of companies, and they're pretty competitive, so I think that lobbying could be really effective. Obviously, this sort of training, both for interpreters and also for providers on how to work with interpreters, requires a financial investment, but it's also important to remember that using interpreters can decrease costs by reducing readmits, more testing, et cetera. Thank you.
Hi, my name's Carl Steinberg, and it's really an honor to present to such an eminent group of committee members and some other friends and colleagues. I'm a long-term care geriatrician, or as I like to say, sniffologist, and hospice physician out of San Diego. My main claim to fame is that I take my dogs to work with me every day. But I'm here really on behalf of the Coalition for Compassionate Care of California. And this is the agency that, building on the work of Oregon, brought PULST to California. And we did it here by way of a legislative fix or a legislation, AB 3000, that put it into effect. But we're in our 15th year of existence, and we do a lot of other things. And I would like to recommend to the committee that using a coalition-based approach can be really helpful, because you have policymakers, you have providers, you've got large healthcare organizations, and all the way down to the direct caregivers and so on. And so we've got 25 local and regional coalitions that work with us. And We do a lot of other things. We've got patient care information that has to do with some of the end-of-life issues, like tube feeding, CPR. I think one thing, if we could change the public perception of what CPR actually looks like, people think that it's like on TV, you know, little lady has a little cardiac arrest, they do a little couple of jolts, and then she's dancing out of the hospital the next day. And I think we all know that's not true, but the public really doesn't. Another thing, the notion that dying from dehydration or hypovolemia is somehow a horrendous or horrible way to die. I think it's really important to get the public engaged. They talk a lot about language and, you know, how we say things. I think most of us know what end of life is. We know what death is. It may not sound pretty, but we're all on that bullet train, you know, and that bullet train's speeding up all the time. And so I think the public, when I talk to my patients, they are receptive to that. That's what it is, and I don't know that sugarcoating it really helps. Anyway, back to our coalition. We're doing a lot of things, multicultural things. We've got some specific documents for the developmentally disabled and making their end-of-life choices to the extent that they're able to. We're working on some outpatient palliative care because I think, you know, it's like other folks have said, we're doing fairly well in the hospital setting, but we really need to push it out. We're working with employers. They're doing it with their employees. And hopefully from there, that also goes into the patients that we serve. Anyway, great to be here. I guess I have till 3 o'clock, right? I can just keep. All right, thank you very much.
Hi, I'm John Stonestreet, and I'm the founder of Hope Care. And just a moment ago, one of the speakers up here read a quote from a venture capitalist that said that we need to create a platform for fresh-eyed entrepreneurs to ask naive questions. So I am that fresh-eyed entrepreneur, and my naive question is whether or not this committee will support my company, my startup, Hope Care, in going to the FDA and to CMS to ask for regulatory approval and also reimbursement for a patent-pending method and system and device that facilitates what I believe we can all probably agree here that we need. And when I say we can all agree, I mean not just this room, but outside of it. Perhaps we'll never have the folks, the Death with Dignity movement and the folks who are concerned about death panels singing Kumbaya together in the same place, but I think the whole country agrees that we need better communication in end-of-life healthcare, and everybody wants better resources for that. And there's a general recognition that there needs to be reimbursement for it. There's some fear around that, but there's also a lot of energy around that fear. And that particular community that has the most fear also wants there to be support for spirituality in the public square. And we just saw in some of these videos and in conversations today that parsing out the relationship between medical care and spiritual and religious hope at the end of life is something that's vital to so many patients and families, and something that perhaps could be a first step upon which we could all agree for moving forward in the difficult minefield of navigating a future of reimbursement for the things that we can all come together on. So my naive question again is, will this committee partner with my startup company, Hope Care, in advocating for regulatory approval and reimbursement with the FDA and CMS for the first step towards this future that I've just started to articulate? Thank you.